Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show, bringing another really awesome guest today involved in creating a better tomorrow for many people out there. Today, we have the honor of being joined by Dr. Darshak Sanghavi, who is Program Manager in the Resilience Systems Mission Office at ARPA-H. There he heads up the Healthcare Rewards to Achieve Improved Outcomes, or HEROES program, which ultimately aims to trial and validate various, radically different approaches to creating preventative care incentives in our healthcare market, and ultimately looking to successfully implement preventative care campaigns that improve the rates of specific health harms in an entire geographic population. Dr. Sanghavi joined ARPA-H back in May of 2023 from Babylon, which is a digital-first end-to-end healthcare provider serving more than 24 million people across the globe. There, as Chief Medical Officer, he was responsible for overseeing the company's international operations, as well as leading its wider mission to bring affordable and accessible healthcare to folks worldwide. Previous to that, Dr. Sanghavi worked as a National Chief Medical Officer for UnitedHealthcare and OptumLabs, also as a Group Director at the Centers for Medicare and Medicaid Services Innovation Center during the Obama administration, Managing Director of the Engelberg Center for Healthcare Reform at the Brookings Institute, and as a pediatrician for the United States Indian Health Service. Dr. Sanghavi has a doctorate in medicine from Johns Hopkins University. He specialized in pediatric cardiology, training from Boston Children's Hospital. He's also a best-selling author. You can find his book, A Map of the Child, A Pediatrician's Tour of the Body, at all major booksellers, and he is a regular contributor to New York Times, Boston Globe, Washington Post, and other dailies. We're honored to have him. A lot of really interesting themes to get into today. Looking forward to the conversation. Dr. Darshak Sanghavi, thank you so much for taking time to come on the show.
Great to talk to you. Thanks a lot for having me on. Looking forward to the conversation.
Yeah, a lot of really unique themes to get into. Would love to start off at the beginning to just learn a little bit more about you in terms of your background, a little bit about why medicine, why pediatrics, and obviously pediatric cardiology, such a really detailed and specialized segment. Love to hear a little bit more about your background, Darshak.
Yeah, well, that's really nice of you to ask. And I think that, there's this temptation to kind of like take a career and have it fit into like this kind of, as if like I had some kind of master plan or kind of this thoughtful approach. And as many of us learn, that's not always the case. Although there are certain themes that come up. And I think as time has gone on, I've realized, over time, the things that get me really excited. And there are little themes like that. And so maybe going back to like, I when I was in, I grew up in New Jersey. My parents are from India. They're immigrants here. And like every other, Generation X Asian American, I was sort of predetermined to go into medicine or healthcare. But what changed for me was like when I was in my training, both in college and then in medical school, that was sort of the post-HIV era, where like, it was like killing all these people. And it sort of like it put the seed in my brain. And, I looked to great authors. Like I remember reading And the Band Played On by Randy Schultz back in the day about HIV and like looking at advocacy. And it was also the nascent time of the Human Genome Project. And it became clear clear that healthcare and medicine in general, it was incredibly scientifically powerful, but it was also seated in a much broader rubric of like, healthcare policy and how do we actually get it, end to end. And now we think about that pretty routinely. At the time, that was really transformative for me. So I ended up actually, when I was in medical school, I was like, oh, health is not just about the patient in front of you, but it's about how do you make it broader and more expansive. So I ended up like, working. I did a tuberculosis control project in Peru. I worked for the I got this. I volunteered and I got a fellowship to work for the Department of Health in the state of Kentucky to help them write their first statewide health survey. And interestingly, trying how do we get people who might be even in interpersonal or domestic violence situations to talk in surveys. I worked in. I took a year off and even worked in the lab to say, well, how do can we create medicines for autoimmune diseases? So it was this incredibly kind of rich time. And what I'll sort of just cut to the chase. The thing that really then shifted my career was in the mid 1990s when I started my residency at Boston Children's Hospital, training in general pediatrics. I love children's health because in many ways, children's health is it's not just about the biology of the kid, but it's about the home environment. It's about like all these other things that kind of shape them. And I really kind of was excited to participate in that type of kind of applied science, so to speak. But the thing that really shifted my career was and some people may remember this. There was a famous murder that actually took place in 1997 in the Boston area. There's a little baby named Matthew Eapen who had been potentially killed by his nanny, who was from Britain. The nanny's name was Louise Woodward, and this was huge front page news at the time. And it was like this sensational trial. Actually, the same folks who had defended O.J. Simpson, another trial of the century, had come in to defend. And what it does is that addressed and it occurred and implicated or involved a lot of the clinicians that I was working with and training with, at Boston Children's. So what you realized is that we needed to do a better job of explaining science and engaging the general public and saying, well, how and you could see that, we deal with that even today with misinformation. Like, how do we better communicate? But at the time, this trial encapsulated it all. So it sent me on a journey, which is sort of, I think in some ways, led to even the HEROES program, which I know we're going to talk about. But that was what, led me to most residents would take 2 weeks off to an elective, like, oh, I'll go, do dermatology or, hey, I'll work it. I said, I'm interested in doing an investigative journalism elective. When they were like, what's that? I'm like, I'll figure it out. So they, to their credit, just gave me time off. So I got to know the lawyers in that case. I got to know the detectives, the judge. I spent, it became like a 6-month or year-long kind of project. And I wrote a long piece trying to explain this trial in a nuanced way. And that's what, after I finished my residency, became a nidus of a book that I wrote that you kindly mentioned. One of the chapters is that story. So I was really lucky to get that entry point. And that then sent me on a journey more broadly to say, well, how do we ensure that we not only do the science and do the medicine, but ensure that the lessons and the information is also not only presented in a way that is fair and sort of thoughtful to people, but also actually creates meaningful change that then helps populations to scale. And I think that insight is what has sort of powered me in a variety of different areas, which sometimes seem unrelated, but that's always at the heart of what I think I'm trying to do. So hopefully that's a little bit of helpful context of like at least the things that drive me.
Yeah, no, I really enjoyed that. As I was taking sort of a journey through your publications at the time, and I learned, you're sitting there publishing about the Norwood procedure and how you rebuild aortas and these unique birth defects, pulmonary atresia, and issues with the autoantibodies at the folate receptor, and doing the really complex cardiology, cardiogenomics. And in 2011, you write a fascinating article in The Lancet entitled "Unexpected Life Lessons from Cardiac Anatomy and Physiology," where, as you were just saying, You go beyond cardiology here. You say, yeah, there's this heart, it's a pump, but it teaches us other things. It teaches us about cadence in life. It teaches us about resilience in populations. You're talking about these children that, have these amazing birth defects, but nonetheless, they're resilient. Say a few words about 2011 and why you wrote this specific paper.
Yeah. So I think that, I think that one of the things I love about written words and language and writing is it sort of taps into these different parts of your brain. You've got whatever the left brain and right brain, where you've got all the science and technical, but then you have narrative and mythology and color and connections and social, like all that stuff. And one of the things I love about writing is that it sort of acts as a bridge between those two areas. Like we can then take license to see metaphor where, in the molecules and cells and in those organs. And, the heart, like what better organ to be infused with metaphor than the heart, we think about it. And that piece that I wrote in many ways, like sort of thought, it brings up like that way of the heart is so much more. And honestly, that was part of a longer narrative journey I had been on. So the Lancet like gave us the ability to write these kind of thoughtful essays. At the time, I was also writing longer narrative pieces for like the New York Times Magazine and the Boston Globe Magazine. I was doing radio and television. And one of the things I loved about writing for more scientific publications was like, all right, these are some of my people. I'm going to like try to sort of tell these stories in ways that also get people that are more sort of sciencey oriented in these publications to also see the beauty in the work they're doing. And most importantly, to inspire them, and maybe just as I have been inspired by other writers like Oliver Sacks or Lewis Thomas or Atul Gawande or others, to actually say, look, that world is so much bigger. Let's actually embrace that. And ideally then do something good at scale. Like, yeah.
Outstanding.
Yeah.
Talk about, a couple of years later, it comes 2013, you start publishing quite a bit on healthcare finance, on healthcare reform, some of the themes and your Brookings at the time, you're talking about themes like primary care physician led health reform, the importance of innovation. You bring in this topic of you term physician realization that they sometimes have to be a CEO, even though they don't, they want to practice medicine. There is a business here. And so you're publishing a lot about these themes. And then come July of 2015, Journal of American Medical Association comes paying for prevention, a novel test of Medicare value-based payment for cardiovascular risk reduction. Obviously, this is laying the stage for what's happening, a decade later at ARPA-H. But let's talk about this because you're at the Center for Medicare and Medicaid Innovation. We profiled Liz Fowler last year. Talk about what was going on at this time, because clearly, this is obviously the major killer of all of us in terms of cardiovascular disease, hundreds of billions of dollars of cost. Talk a little bit about, how you set up thinking for a program at the time in terms of prevention as it pertains to cardiovascular disorders.
Yeah. That for context, the Innovation Center, as I think many of your listeners are aware, it was really this kind of amazing new center funded with $10 billion as part of the Affordable Care Act. And it was brand new. And they had these couple superpowers. First of all, they had money, which is fantastic. They also had regulatory authority, so we could waive CMS regulations in the pursuit of sort of doing things. We could then design these kind of completely out-of-the-box programs. Like that had never been, at least at that scale, not been, they had been pilot programs, but to create a whole center. And then most importantly, there was this other thing, which is that if your experiment worked, and by worked, it meant if it was actuarially stable or saved money, or it improved quality by keeping costs the same or better, you could expand that within the Medicare program without going through Congress. Like, what an amazing thing. So the way people thought about CMMI was they said, well, look, let's focus on things that save money, right? So that's when they came up with like bundle payment initiatives, primary care, ACOs. But keep in mind the fundamental issue there is how are we going to save money? Because everybody's like, well, Medicare is going to run out of money. And there were 3 or 4 groups that were doing that. So I was recruited by Rahul Rajkumar and Patrick Conway, who had been at CMMI. And they said, look, we're doing all this stuff. We want somebody to come in and think a little differently, maybe focus on kind of these other areas, like how are we going to really produce benefit and actual prevention that's a little bit focused. And here, you know what? You figure it out. We've never had a permanent director of this group before. Come on in, hire a team, bring them in. I mean, what an incredible opportunity. So it was into that we walked in. And then our team, and I was so lucky, these amazing colleagues like Dawn Alley, who came from the Office of Surgeon General, Von Nguyen, who came from CDC. We had a small team there. And we sat down and we said, well, what are the biggest problems in America today in terms of health, not in terms of cost? And as you point out, number one was cardiovascular, right? And so the question is, well, how can we make that better? And how do we do it in an innovative way? So the thought we had was, look, well, it's nice to, we spend a gazillion dollars. That's a technical term, I guess, in Medicare. Even if you can move that like a few percent, that's more than any grant or public health. In the insight was CMS and the ways in which we spend money is public health. That was like the fundamental insight we had. So how do we spend it in a way that truly improves public health, keeping in mind the spirit of CMI? So here's the idea we came up with. And this was like a credit to so we said, okay, the problem we want to solve is we can't pay for stuff today where the outcome is potentially 5, 10, 15 years in the future, right? That's the problem in prevention. How are we going to make that better? We said, okay, let's think about how we do that in markets. We securitize a future risk. We create a value in the future and we sort of amortize it over time. That's how you buy a house. That's how you do a mortgage. Could we do that with heart disease in some way? That was the central insight we had. And I hope it's okay. I'll get into a little detail because sometimes the devil's in the detail.
No, please do.
And we said, well, okay, we need to do this in an evidence-based way. So I knew that at that moment in time, the American Heart Association had created something which had a terrible name, the American Heart Association, American College of Cardiology, Atherosclerotic Cardiovascular Risk Detection. Terrible marketing, right? But here's what it did. You could go online, put in your age, your birth sex, your ethnicity, your systolic blood pressure, just 7 or 8 simple pieces of data everybody had. And if you were over 40, it would tell you the risk of heart attack or stroke that you had in the next 10 years. In other words, we actually had a validated, widely accepted metric that already securitized future risk based on that percentage. The insight we had was, let's take that number. Let's calculate it for everybody in Medicare. And then if you're a doctor, we give you that number. You average that number across your Medicare patient population. That's your panel risk. And you know what we're going to do? You figure it out. If you can improve that risk, and we'll calculate everything on the back end, you get paid. So we created a payment for a future outcome that would actually accrue to the physician based on that. It's actually a scalable approach for sort of securitizing any future outcome. That was the central insight. And then we did a couple things. The first is there's all this crazy technical stuff. It turns out the calculator is like cross-sectional, not longitudinal. Some of your listeners will know what that means, but that's a big problem. Yep. We figured that out. We published a new calculator within 3 months. The other issue was that we didn't have the tools that are available. So we created tools that could be plugged into Epic or other major vendors so physicians could do this. And then we even worked with folks to create a randomized trial. So all that was done. That was the Million Hearts Cardiovascular Risk Reduction Model. So we put it out there, randomized at the practice level. To date, the largest randomized trial ever of paying for a preventive outcome ever performed. It included about 3.3 million Medicare beneficiaries. And all we tested was, look, we're just going to tell doctors, if you do this thing, you'll get paid per member per month. It's actually not a lot of money, honestly, between us. But look, we'll just put this in front of you because you want to do the right thing. Like people are tortured by all these metrics and measures. We made it super simple. And the amazing thing, and the final results just came out recently, not only did we reduce the rates of heart attack and stroke remarkably, it actually, and this is very hard to do, even showed a mortality benefit. Just that simple thing. And if it was scaled across Medicare, what we estimate even more, that's like, a Super Bowl stadium sized number of people that would be alive as opposed, with that model now. So that was the example of how we took these ideas. And this is one of the reasons why I think it's great to have people that have experience in various sectors. We had people from public health. We had people from the payer space. We had subspecialists from the clinical side. And then we had like this kind of nutty vibe of like, let's try crazy stuff. And we threw all that together. And then critically, we had a couple people that understood how to actually write and navigate government. So like when we put that together, that was like the nidus by which we created that amazing program. And that sort of those, we did that. We did a number of others that were similar to that over the time I was at CMMI. And in many ways, that notion that simple tweaks or kind of thoughtful approaches here could lead to massive changes, that's sort of what's kind of, again, continue to animate the work I've been trying to do.
Mm-hmm. And just and we'll get to ARPA-H in a minute, but just for the the audience sake to understand that Dr. Sanghavi looked at more. You're involved in more than cardiology at this time, and again, you're publishing. I noticed on proper opioid stewardship, exercise in cancer care. But at the other end, you're doing this really cool stuff with artificial intelligence and machine learning and dementia. Innovation. It's kind of a broad term, and when we get to in the prevention world, I think maybe a lot of folks think innovation is all about the AI and the CAR T cells and the gene therapy and stuff, but there's a lot of low-hanging fruit. Talk about what innovation means to you in terms of prevention.
God, I love this question so much because oftentimes, here's the thing, and I think this is what you're getting at. To me, innovation, it's not about the tool, but it's about, you got to start with the problem you're trying to solve, right? Like, if there's one thing like I feel distinguishes effective kind of approaches from ones that are not effective, it's when you focus on the outcome rather than the tools. Because like too often we're like, oh, we've got AI, how are we going to use AI? Like, as opposed to, we have people that are overdosing nationwide because we are misprescribing opioids. How are we going to solve that? That is how I always get started. So innovation to me, like, let me give an example around the opioids since you brought that up. So when I was really fortunate to be a part of an amazing team at OptumLabs, which is sort of the R&D hub at the time at UnitedHealth Group. And they had this amazing data set. They have this thing, the OptumLabs data warehouse. We had claims of like almost 150 million lives over long periods of time. And that was linked to EHR data. The thing is that we had a lot of very, very smart people, but this is the thing, we weren't using that in a way to solve a meaningful problem. So part of one of the things my team was able to do is say, look, let's go to exactly that. We're going to innovate, but we're not just going to innovate in tool sets. We're going to innovate because we're going to have impact. And the problem we chose, it was right around the time, some people remember, Vivek Murthy, the Surgeon General, had sent out a letter to all the doctors in the country saying, hey, guys, can you, and they got, by use guys, I mean people, like physicians, providers, all that. When you're prescribing, can you just kind of just make sure you give a 5 to 7 day supply. Please don't give more than 30 to 50 morphine equivalents. Don't prescribe if they're on like benzodiazepines, all that stuff. So physicians nationwide got that letter. And that was really important. Here's the thing. There was no metric associated with it. There was no accountability. It was just a letter being sent out. And I think all of us can get that, a letter being sent that I and every other physician, when she goes out to open it, reads that thing, who knows whether that has impact. So here's what we did. Something very simple. We said, we are able to actually look at prescribing patterns of tens of millions of people. Our team hacked together a performance metric within 3 to 4 weeks. I had an amazing team led by this incredible PhD scientist, Aylin Alton, and a number of other folks. We put this together. And then what we found, and we did this across the Optum book of business through OptumRx, and found that only 50% of all of our first-time opioid prescriptions were in compliance with Dr. Murthy's recommendations. Incredible, right? 50%. And not only that, when you did a bell curve, it was like completely random. It wasn't like this was a problem in Florida or in Massachusetts. It was very inconsistent. So that's the kind of, like, that's innovation, because we first drew a meaningful insight, but then importantly, we all said, well, what are we going to do about it? So the next part of innovation, it's not just the problem finding, it's also the creative solutioning. So if there's the first innovation precept I have is like, please find a problem that's worthwhile. The second piece is don't just admire the problem, but please innovate in solutioning around it as well. Because too often we're like, oh, we're just going to do predictive models. But I'm like, what am I going to do with the predictive model? I don't have a thing I can do about it. So that was the thing. So then we innovated working with an amazing team on the OptumRx side, a guy named David Calabrese, Sumit Dutta, like a bunch of others. And we actually pushed through something, and this was like a credit to leadership, a nationwide hard edit. Lots of challenges with that. But what we went from 50% compliance to 90% compliance nationwide at massive scale. Tens of millions of people were then getting prescriptions in compliance. Was it perfect? No. But also, we looked at the back end. We reduced by 50% the incidence of new chronic opioid users as a result of that. So that's innovation in my, like, was it AI? No. Literally, we were just counting stuff. Like, if you look at it was like addition. It's like and or. That was the key part of the innovation, was just the idea. And I would submit, if I can build on this even a little more, that in my view, data is a commodity. The thing that is in short supply is not like obviously we need better data. Data should be easily accessible. But the thing is not the technology and the techniques. If there's one thing I believe innovation depends on, it's that. It's the individuals who can come in and see the problem in a new way and a creative pathway to that solution, in a way using those existing tool sets. So that's the thing that's in short supply. Everybody's got data, everybody's got tools, they've got fancy LLMs. What I really would like to see more is like a better definition of the right problems that people are trying to solve.
Mm-hmm. And you've clearly picked the mother of of problems, and I would love to hear just a little bit. As I mentioned in the bio, you arrived at ARPA-H last May, and obviously we've been profiling some of your colleagues, and I think when ARPA-H comes to mind, okay, it's this highly secretive bleeding edge technology. You're knocking on the door. I don't know. I'd love to hear about the process, because you're getting there saying, hey, look, preventative healthcare is not working in this country. It's a $4 trillion problem now, and most of it is these chronic degenerative diseases that have a major slice of prevention involved. Talk about May 2023 and showing up at ARPA-H with this concept.
So ARPA, I have to tell you, it's an amazing place. I'm so grateful to be part of it. And the way it came about, I just think also it's good for us to demystify how these things happen. So I remember, I honestly, can I tell you, I had never heard of ARPA-H until I didn't know what it was. I'd heard of DARPA, like a lot of people had, but I remember actually, just talking. One of the things is I was just at an event, and I remember speaking to somebody who was, we just got to talking. It was over a glass of wine, and I think there's some pizza there possibly. And nice. They said, well, look, there's this, and I think that was the time I was like, hey, I want to do more public service, like the way we all are. Like, we're always trying to figure something out. Like, who among us is has everything? And this person started saying, well, there's this new agency called ARPA-H, and they click through there's going to be $2.5 billion. There's these role called program managers. We have independents because we report directly to Secretary of Health. And the thing, I was primed because I had been at CMMI, at the Innovation Center. In government, it's sometimes hard for outsiders to find the really good and impactful jobs versus the ones that may not be as impactful. But given my experience, I knew what was being offered. So that was one of the reasons I signed up. I think I'm the first MD that actually signed up as a program manager, because it was so exciting. And the way it works is, as a program manager, you come in, you pitch a big idea, and they kind of go through it. And if they like it, they bring you in. So the thing I pitched was, in fact, I'd been thinking about this HEROES program for a while, which, simply put, as you said, we're trying to solve the mother of all problems, which is, how do we better invest in prevention as a nation? How do we address disparity? Like, big problem. And the key here was, how do you break it apart into its constituent components and get at the heart of the things where you can have real meaningful impact? That was what the HEROES program did. And so when I came in May, like, I had the outlines of the program in mind. And this is the great thing about ARPA-H. The team there, the leadership said, look, and I think Renee Wegerson, our director, she has this little saying: every 2 weeks that go by, you've lost 1% of your time here. So there's that constant urgency. And he said, look, you've got a couple months, but you make this thing happen. So that was when I walked in. That was sort of the directive given to say, look, you had this idea, we like it. Like, we're going to bring you and we're going to invest in you, but now you better deliver this thing as soon as possible and make it go live. So that was the challenge we took on. That's what challenge all program managers take on.
Excellent.
Yeah.
And within the sort of the initial portfolio, sort of the basket of, I mean, you have obviously cardiology and stroke in there, and major killer, which we talked a little bit about. You have opioid use, alcohol use. The one that popped out at me, this was, well, it wasn't surprising because I did do an episode on these obstetric complications, and Merck has this foundation that it has something called Merck for Mothers, and when I was originally talking with them about this, and they were talking about issues with Bangladesh and Nigeria and all these, and the United States is on this list. I'm looking at these numbers, I'm like, oh my God. I mean, what's our issue here? I didn't even realize it was an issue, but this is just another piece. I mean, obviously, there's a life continuum here. You're a pediatrician as well. I'd like for you to go through sort of why you picked these 4 items in the basket. But if you could start off at sort of the beginning of life here with these obstetric complications and walk through why you picked the others as sort of the initial.
And maybe if it's helpful, I'll just give a little context for kind of viewers that may not be as familiar with what the program is. If I just lay that out, then it'll help sort of people contextualize these little pieces. So the ARPA-H broadly, we're like the moonshot agency, right? High risk, high reward research. It sounds like you had Ross Urich on, amazing guy. He's like, how are we going to regrow joints with just a single injection? Ileana Hanku, amazing scientist. She has this idea about augmented surgery. So the first time you do surgery, you do it right, So it was interesting because my program, part of what was really great about ARPA-H is that expansive thinking. Many people think innovation is just like, we're going to print organs and like grow cells. But innovation, it's just as important innovating around how do you deliver care in better ways that get to all Americans. And that was actually a big leap. And I'm grateful that ARPA-H decided to make that, part of its mission. It was not a given, but it's innovation in behavioral economics, technology, all that, but in a way that's applied. So having said that, the program, at least the problem I was trying to solve was this, is like, let's take let's look at opioid overdoses. Everybody knows that's a big, big problem, right? Yep. We know what we're supposed to be doing. This is the other thing. We know that, it's important to prescribe well, but it's also important to make sure that individuals who have opioid use disorder get evidence-based treatments, like medication treatment, buprenorphine, get counseling. Make sure, there's all this stuff we know we should be doing, and yet less than 20% of Americans who have OUD are actually getting evidence-based care. So why is that? When we spend the most of any country on healthcare, and you can go down the list, same thing with cardiovascular, same thing with obstetric, why are we not performing? And it's because of 3 problems. The first is there's no incentive. Just like we securitize cardiovascular outcomes, we talked about it, that doesn't exist. Nobody is going out. I'm talking to you from the office here in Boston, Massachusetts. Nobody here is paying anybody to prevent opioid overdoses in the city of Boston. So that's one. There's not a market. The second is, even if they did, who are they going to pay? Because look at all the payers. They're so fragmented. Nobody owns that market. So even if somebody were to say, look, I'm an insurance company, I want to help my patients, it's only a small sliver. So the first is lack of incentive, second is fragmentation. And the third is this, and I think many people get this. If I were to say to people, how many overdoses occurred yesterday in Boston? Nobody knows the answer to that, right? Think about that. If I were to say, well, how many obstetrical health data? So that's what the HEROES program does. And so what we said is we're going to rethink the overall ways in which we create a market so that we actually innovate and invest in these kind of population-wide strategies. And at the heart of Heroes is something very, very simple, which is we simply do this. We create a geography. Everybody who lives in that geography is like in the denominator. An organization comes to us, they said, look, you pick one of the 4 issues, which is what I'll talk about. If you pick it, we're going to track that, and we'll pre-purchase an improvement in that outcome, so to speak. So if you make overdose rates better, you can make up to $15 million, and we'll help you find matching funding. You could make up to $45 million if you actually improve the health of a community. So that's the business case. So they go out, they could raise their capital, they do all the cool technology investments. We don't tell them how to do it. Local control, critical, right? Like the way you're going to handle overdoses in Boston is different than Nashville, Louisville, Houston, Provo, Utah. All that's going to be very different. So that's at the heart of it. It's simply creating that market, and that has never been done in American healthcare. So huge, big moonshot. So then I think this is a long way to back into how do we choose those 4 things? So we said, look, we want a model that looks like America, and we want to look at problems that really do lead to long-term harm. So just as I think I mentioned CMMI, we looked at the list. What are the sources of misery in health today? Cardiovascular, right up. So that's why we took the Million Hearts model and we scaled it. Ours is going to be everybody 40 to 70 in an entire population. Can we improve their risk? That is a big goal. So that makes sense, right? Heart disease, big problem.
Yep.
Also, it's generally older people, right? Like, you can start preventing over 40. It's really a problem more of the older populations. And there's a heart disease kind of area. Opioids is very different.
Right.
Very different kind of demographic that's affected by opiate use disorder and opioid overdoses, different geography, and importantly also a completely different set of strategies, but also the leading killer of people. So, again, going down that list, alcohol use disorder, something we've actually just sort of gotten inured to, right? Like, again, you just look at that list of there's a bunch of these lists that are out there, Robert Johnson Foundation, the team in Seattle, others, and then obviously maternal complications. So we chose those because we felt that those also look like America. We got young people, we got kids, we got young adults, we got older people, we got a wide demographic and geographically diverse set of outcomes. That's one of the reasons we also chose those. So we had a program that looked like America.
And talk a little bit about you define sort of these health accelerators, which can be, I guess, lots of, for nonprofits, care consortiums, it can be many different things, could be a health accelerator. Talk a little bit about what you envisioned there.
Yeah. So let's take this on. Let's say we have this bold goal. I don't know, take the state of let's take the greater Atlanta, Georgia area, only because my son's going to be moving there this summer when he graduates college to take a job. Nice. So, obviously a significant area of, let's say, obstetrical complications. We know it could be better there. So let's say we look at those numbers and we say, well, what's at the heart of the problem? What are we trying to solve for? And you realize this is why it's so important to be quantitative. Our metrics are super clear. When we say obstetrical complications, we mean something very specific, which is the 21 bad things that happen to somebody when they deliver. Bleeding out, heart attack, sepsis, pulmonary embolism. There's a list of 21 complications that are unburdened. We are super clear. We want you to improve those, and they're claims-based. The thing is, those measures, they're only in the hospital. We want people to be healthy, not just there. So we extend that time frame claims for 60 days postpartum. It turns out about a third or more of maternal mortality actually occurs after they leave the hospital. And many women get no care. And we also need to include mental and behavioral health issues like self-harm, overdose, interpersonal violence, hospitalization. So that's what we're trying to solve. I want to be clear on what the metric is. So you say, if I came to you and said, we can maybe give you $45 million to fix that in this kind of geographic area, how would you do that? This is the key for a health accelerator. No one has ever come to somebody and say, look, we'll give you money at that level in an accountable way to improve the health of the community. So let's say they look at that. Here's what you would see happen. We know that one of the most effective ways to improve the care of women when they're delivering is through sharing information and hospital-based protocols through something called this sounds like so kind of basic, but it's incredibly important, which is just sharing data and practices. California's done this, the California Maternal Quality Care Collaborative. Again, super unfun acronym, but incredibly impactful. Same thing, could we share practice? So a collaborative could come into place. It could be a large set of payer providers as well. It could then be an organization, like let's say, so you can see how I'm building it might be a care collaborative. It might be a set of hospital systems. It might then be a digital health provider that says, look, one of the big problems is only 25% of women on Medicaid ever show up for any postpartum care after they leave the hospital. That's not acceptable. We will find them and using technology and digital tools, engage them in care so that after they leave the hospital, they'll get what they need. They get, all the stuff, screening for social needs. They could get if they have issues with nutrition for their children, if they have challenges around anemia, like hypertension, get them engaged in care. And then potentially even invest in approaches to get their entire family into care as well. Because when a family is healthy, the mother's also healthier. So we leave it to them. So that consortium comes together. They would be the applicant as a health accelerator. I'm giving a little bit of detail around that, but that's sort of, you could say, look, if you want to address opioid use disorder in LA County, how would you do that? Well, we'll have these folks that go out to different ERs, they'll do this work. The key is that we don't want to just double down on the same old thing, which is paying more through the traditional healthcare system for hospital-based care. We're creating a capital pool that others can use to do all the stuff we keep talking about, but never gets done.
And just take us. I know there's there was a technical assistance webinar a couple of days ago. There's a few coming up in April. Talk a little bit about sort of where we sit with regard to the program now, because again, as you're just pointing out, because these accelerators can be many, there's obviously going to be many of them. It's not like with some of these other programs we've been profiling, hey, we're going to pick that lab to do our brain regeneration work or whatever. Here it's much more fluid and extensive. Talk a little bit about where things sit as of 3/28/2024 as we're talking.
So I'll be very what we say, tactical around this. So right now we have a draft solicitation, meaning anybody who's interested in participating, or you can go online right now. You can sign up on our teaming page, say, hey, I want to kind of learn more about the program. You'll get introduced to others that might be in your area, other funders, because we ask for matching contributions. That can all be done. And you can read the entire solicitation, meaning that's a fancy term for saying what the application looks like. Now, the final application we anticipate is going to be posted next month. That application is going to, and we've really tried hard to make it easy to read. This is not like your grandpa's government agency. I encourage people to take a look at it. We tried to make it understandable. We tried to make it easy. And here's the thing. The applications will be open then for 2 months. So we're anticipating sometime in April, and you'll get 2 months to put together your team and all that. There's going to be technical assistance. All those webinars are there. But here's the thing. The application, we are super efficient. It's 7 pages long. Again, when's the last time a government agency asked for a 7-page application? And then we'll sort of pick the kind of cream of the crop from those applications, and then they'll get the chance for a full application in the program. We are going to go live early next year, so very aggressive timelines. That is very, very quick. I will also say that all this information is on our website. Go to ARPA-H. Heroes. If you just Google that, you'll find it. We've got a ton of information there. And again, I want to emphasize, it's really easy to navigate the site. You can see all our webinars. You can see our Proposers Day. If you read the New England Journal of Medicine, we published a paper, only 1,100 words, explaining the program. You can take a look at that as well. So we're going to be open for business starting next month with applications. My fervent hope is that we get incredibly well-qualified applicants that are truly dedicated and can help move the needle on these outcomes.
Excellent. And as Dr. Sanghavi was just mentioning, New England Journal of Medicine, January 25th, 2024, Transforming Population Health, ARPA-H's new program targeting broken incentives. No, it's so exciting. Well, obviously for you, but seeing that this something like this get put into motion, obviously, prevention is something that we talked about for decades now in terms of ultimately how we put it into practice. But clearly, I think the stars are aligning now, and I wish you and the best with all this as it evolves into 2025. Darshak, anything I missed while we have you? Clearly, things are happening in real time, but any other initiatives besides the upcoming webinars that we should know about in terms of the program, anything that you're doing in general
Yeah,
that in terms of conferences, talks
yeah.
on this topic or others, please have the floor.
Yeah, absolutely. So, well, here's what I would say is, please, ARPA-H, sign up for our newsletter. Like that's sort of the easiest thing just to see what's going on. I think we're doing a bunch of cool stuff, and for this if Heroes is not the thing you're interested in, there's a bunch of other stuff we're doing that's really cool. We have a women's health initiative. I'm one of the program managers that's on that. I have a portfolio in cell and gene therapy. Interested in sort of a better rate screening tools for newborns. Like each of us have actually a number of areas that we're working on in addition to our program. So ARPA-H, we see our role as trying to push forward and accelerate healthcare in a number of areas in partnership with the incredible innovators across the country. I want to emphasize, we don't do this stuff on our own. We contract this out. In other words, it's not intramural, it's all extramural. We really want to leverage innovation in America, and we are super diverse in how we think about that. I will say with the Heroes program in particular, if people are out there listening, this is one of the highest risk, highest reward things, in my opinion, ARPA-H is doing. I can say that because it's my program. But it really will only succeed if we get people to participate and take a risk. This is the whole thing. It's not a sure thing. Like putting together a consortium in a state to handle this hard problem, that's a really hard thing to do, Can I guarantee you we're going to succeed? I can't do that. But what I can do is to say, there's so many people out there, they're so frustrated by healthcare today. They look at all the stuff, they're like, oh my God, the payers are messing up and primary care is bad. And this is the thing. They're out there. This is a chance to at least try to be part of the solution with an organization that's trying something new and trying something really fundamental. Even if we don't succeed, my hope is that those people that spend the time to apply and get engaged, hopefully they'll be richer for it in some way.
Most definitely. Most definitely. No, again, I wish you the best with it. I think you're clearly setting it up to succeed. So I'm excited and we'll be excited to continue to watch you in 2024 and as things get more live in 2025. Again, for everybody who's going to be listening to this show across the various podcast networks or watching on the YouTube channel, again, you've been spending time with Dr. Darshak Sanghavi, Program Manager, Resilience Systems Missions Office, ARPA-H. We will put the link, obviously, to his bio in the bio of the show, as well as the Healthcare Rewards to Achieve Improved Outcomes or Heroes program page. And Darshak, again, I want to thank you for taking the time out of your schedule to talk to us for a little while about what you're up to there. Obviously, thank you for what you do. And as we like to say on our show, thanks for helping to create a better tomorrow for millions of people out there via what you're attempting to do here. Really a great story.
Thank you so much.